need your password. Shall we begin?
It's up to you.
You ready?
I'm ready.
Ready?
I'm ready.
Let's call this meeting to order. Thank you, everyone, for joining us. The special meeting of the Board of Directors. This is, well, really, Crystal's show. This is all about the budget. So, start with a roll call.
Director Brown. Here. Director Darzengevich.
Here.
Director Wong.
Here.
Chair McGarry.
Here.
And I show Director Chamblin absent.
Correct. All right, clearing the agenda. Anything on the agenda to be pulled, changed? No, no, no. All right. We only have one item for board action, and that is the fiscal year 2026 budget, actually two, and then the capital plan, which I consider kind of one and the same. So with that, Anna and/or Crystal, I'll pass it off to you.
I will start us. Is my mic on if the light is red? Okay. I'll start us, but as you say, this is our CFO's meeting. But I just wanted to say that two things I want to say is that as I sit here today, I just surpassed my 100th day last week, and sort of now focusing on the next 1,000. I do want to just pause for a moment and just acknowledge the extremely diligent and amazing talent within our finance team, led by Crystal Felix, and Jay Chasseur is also here, who is sort of, if there's any question about finance, it leads to one of the two of them at all times. But I want to recognize them and thank them, along with our staff who have been working really hard, which really puts us in a position to yet again have another strong year here at Tahoe Forest. Our patient care revenue is looking to exceed $765 million this year. I won't entirely steal Crystal's thunder, but we are on a trajectory to be $1 billion in revenue in not so long, in the foreseeable future, which I think is, again, a testament of the leadership, both of our board, our finance team, and all of the staff here at Tahoe Forest, from the leadership down to the people who have been doing all the work. I'm going to keep it really simple for me, just to say that this year I added a couple of visuals, mostly for the public to know. I think a lot of people, when they think of Tahoe Forest Hospital District or Health District, depending on which term you use, they think of the hospital. But as you look on page 2 of the finance report, I'm sort of highlighting out 87% of our business is actually outpatient. So I think that this shift over to the outpatient, I think the complexity of the work being undertaken by the medical staff out there and all those teams on the outpatient cannot be overstated. And it's been, it's a much different operation, outpatient than inpatient. But I just again wanted to draw your attention to that. And just quickly, as we look ahead this year, and you're going to hear Crystal talk about some of these things, you're going to see more expansion into the outpatient services. And one of those things that we are sort of looking to do, and we'll come back later in the early fall, is to, in addition to expanding those outpatient services, we're really pushing as a leadership team and an organization to think about what of those services can we make more convenient and more affordable. So more soon on that. But without further ado, I'm actually going to hand it over to the CFO unless you have any other questions. Yeah, thank you.
I'm wondering, so if the budget was done differently this year, I recall from Jay and to you as well. Is there not more involvement this year? Yes.
one thing. Before she answers that, I want to speak to reality. Reality is changing hour by hour, and you're going to hear a little bit more about that a little bit later. But as a backdrop, as we hear about the great and strong financial position we're in, we are approaching this year as a leadership team with caution. Though we hope we aren't looking sort of at a situation that would be cataclysmic, we are preparing to be ready for anything, given the uncertain times that we're in. So I failed to stress that as part of the backdrop, and part of that, I think that's a really great question about how we involve the staff, and I just again want to acknowledge CFO Felix for that, because we are going to be, I think we are really trying to make the finances transparent so people don't kind of like look at this and go, great, we have a bunch of money, let's go spend it, when we're really in uncertain times. So the more people can see, and we increase the line of sight into the level of uncertainty that we have, the more I think that our staff are then better positioned to help us achieve our goals. So with that, sorry, Crystal, I'll hand it back to you.
That's okay. So a couple things. I will say every year the budget has been built upon the reality we know at that time. So reality is a relative term when you state that.
Very relative this year.
Yes. So, and more in line of what you're asking, we try to engage staff and management as much as possible in the creation of the budget. And this year, Jay took it upon herself to meet one-on-one with every single department director to walk them through their budgets. This is a step this organization has taken in the right direction of ownership at the department level. And not only for their budgets, but also for their actuals going forward. We've talked about management reporting and variance reporting, and this is a journey we've been on for quite a while with some systems we put into place, and we're formally kicking off a much more rigorous process in 2026 than historically, more rigorous with each department. I'm not saying we didn't have the rigor before, but the rigor was more owned in finance, not departmentally. And we're moving more towards rigor departmentally. So definitely more involvement. I think it was eye-opening for some of the management staff. It was very educational. And I think Jay actually enjoyed it because it's not very often we get to meet with every single department. So that was the process we took this year. Sure. All right. Are you guys ready? Yes. Okay. So I plan to tackle this a couple of different ways for information for you. I'm going to start really with the highlights of what the 2026 budget looks like, not only for you, but for the public so they can hear the high level. Some of the assumptions we put into each of the categories and that got us to where we are today. Some areas that might vary from the time we produce this to the information we have today that I'll be sharing with you. We'll touch on capital, some of the larger projects and the investments we're making in the future, alluding to what Annie had said earlier. And then we'll spend some time in the financial forecast section to look at what our financial ratios look like, what our forecasts look like, and what those forecasts look like once turned into ratios, and how the current information we have from Standard & Poor's, those benchmarks, what they look like compared to Tahoe Forest. So we'll spend time in that arena too. We will touch on, as part of the revenue section, a proposed rate increase to our charge master, and that there was information provided to you in great detail in the back of your binder about comparisons, so you would know if that really kind of took us out of the realm of market competitiveness, and we'd give you some perspective on that. So that is what I plan to do this afternoon, and if that sounds okay, I'm just going to dive right in.
How would we best serve you the questions, one thing at a time? What would be the best format, or what's worked before?
The preference of the board to hold questions till I ask for them, or just do it as we go through?
I'd prefer more conversational.
That's totally fine.
Okay.
Okay. All right, so our fiscal year 2026 budget, by the way, when I say fiscal year, our year is a July 1 through June 30. So when I say fiscal year, it is definitely not a calendar year. So fiscal year 2026, we're projecting gross revenue to be $765.4 million. Our deductions from revenue total about $415.5 million. Deductions from revenue include contractual adjustments, charity care, and bad debt. Other operating revenue, we're targeting $22.9 million. We are allocating just shy of $1.5 million of property tax revenues to the wellness neighborhood, thus that line item. So that provides a total operating revenue of $374.3 million. Our operating expenses are totaling $346.7 million, leaving us with an EBITDA line, earnings before interest, depreciation, and amortization. By the way, there's no T in that for taxes because we as an entity don't pay taxes. So just a reminder there. I actually do know what that stands for.
Never does.
So EBITDA is $27.6 million. Non-operating expenses, those are things like interest expense, maybe losses on some sale of assets, things of that nature. $18.9 million. Property tax revenues, we're targeting 15.4. You would add another 1.4 million to that from the wellness neighborhood for totality. That does include the property tax revenues we receive to make our general obligation bond debt service obligation. So that brings us to a targeted net income for fiscal year 26 of $23,958,434. That is a 7% return on equity and a 3.6% return on gross revenue EBITDA line. So that's the global picture. When we create gross revenue, we do it based upon a per unit calculation. You have a section in your binder related to volumes. We review historical use or historical information of our volumes. We try to see if there's fluctuations due to seasonality. We do know we see a little spike in our emergency room during the summer and the winter months. So we take that into consideration when we spread the budget over 12 months. And we also look to see if there might be any kind of growth in a certain category. For example, emergency room, maybe a slight increase based upon trauma. And then we also look at it, are there any new or additional providers coming on board that we're anticipating in 2026? We are expecting a few providers to join us, or just right now are joining us. So we try to accommodate for those volumes within the clinic setting. And then also based upon some new possible services that we could provide, for example, in imaging, there are some thoughts there that might increase volume slightly in certain categories. So we take that all into consideration when we create our volumes. And then that becomes a calculation of volume per revenue per unit. And we look at what our revenue per unit was in the most current year, and we take into consideration the proposed rate increase we're presenting to you today to recalculate that rate per unit, and then we multiply it by the volumes. So that is how we get to our gross revenue projection. In addition to that, we then look at our payer mix. And where is our revenue generated from? Is it from Medicare? Is it from Medi-Cal or Medicaid or commercial insurance? So there is a section back in your binder about gross revenue. And in that section, we were projecting for our fiscal year 25 that we'd have 39.5% Medicare, 16.6% Medi-Cal or Medicaid. County doesn't really exist anymore, 1.2% other, and a 42.7% commercial. We're adjusting that ever so slightly to where we have Medicare at 39.1%. We're keeping Medi-Cal about the same, and commercial just slightly up at 43.1%.
How are those ratios? Are those good ratios to have? Are they bad ratios to have?
Those are amazing ratios to have.
Well, I know that.
Yes.
I'm thinking for the public. that
Public,
might be hearing
yeah.
that. What
Yes.
is that? that means that we were really lucky, we're fortunate to have.
We are fortunate. We have a payer mix that tends to provide a better level of stability. And it, being a critical access hospital, as we are provided what's called cost-based reimbursement for the hospital setting, which is a different payer or a pay mechanism than what other hospitals experience. Our Medi-Cal population is growing. We have seen that over the years. If you were to look at the graphs in that section, you'll see how it's kind of ebbed and flowed and how it changes between inpatient and outpatient. So we try to take all that into consideration and make our best, what was
Educated guess.
educated guess is what you gave me. Our best educated guess of what we think that's going to look like in 2026. That payer mix then gets carried into our contractual allowances. So we look at our inpatient revenue by payer and our outpatient revenue by payer, and then we apply the assumptions of our insurance contracts, how Medi-Cal pays us and how Medicare pays us to get to what we call a net patient revenue. And that's the amount of money we actually expect to collect in the doors to help pay our bills at Tahoe Forest Hospital.
Excuse me, could you give us a little insight into the thought process of keeping Medi-Cal flat?
So I did not make any radical changes to the budget for 2026 based upon all the conversation that is happening at the federal and state level today. None of that has been formally put into place. However, what I did do is kept our charity care and our bad debt levels higher than historically we've seen them. If we see changes within, for example, the undocumented that currently have Medi-Cal coverage, if that shifts to no coverage, we might see additional charity care applications for assistance, or possibly even bad debt in that circumstance. Also, the revalidation of eligibility for Medi-Cal. We may see folks not do their re-verification paperwork and end up not having coverage. So there are definitely some dynamics that I try to consider within charity care and bad debt that did not shift the actual payer mix percentage. The other thing we did do, we'll talk about our supplemental programs here shortly and the dollar values we put in the budget. I will tell you, I went conservative. And I did that because of the conversation around the federal matching amount for that Medi-Cal population with the state of California. So I did not, we were able to negotiate additional funding in those areas, but I did not bring our numbers up significantly because of that, just in case that federal matching or FMAP changes. So I didn't get crazy with what's happening in the federal state, but I feel like we have some reasonable conservativeness around those categories to help us weather it, depending on what goes through.
So is it fair to say what I'm hearing, to summarize, is that there's a lot going on in this world, as you mentioned, like there's changes that happen daily, that we're getting news hourly on from that. And what I'm hearing is obviously, change in charity care, bad debt, you said conservative, not raise, possibly getting more money, but making sure that we're planning that we may not get that. So it sounds like a lot of planning for things that may go wrong, correct? So I just want to kind of make sure I'm thinking of the public and making sure is that kind of the thought that we're overall?
Yes, we're fairly confident something's going to end up going through. Something's going to go through that's going to impact this.
So just be clear, something that's going to negatively impact our ability to be financially successful?
Yes,
Okay.
it will have a financial impact on Tahoe Forest. What we don't know yet is the degree of impact. If everything were to go through as we see it today, it would be, I'm going to just say double-digit impact, meaning 10 million or greater to Tahoe Forest. One of the things that I am grateful for is for our structure. Those that are on what's called fee-for-service where the Medi-Cal fee schedule or the Medicare fee schedule is impacted, we're a little bit more protected from that because of how we are currently reimbursed, Medicare being cost-based reimbursed. So some things protect us a little more than what other organizations might experience, but it's still going to be pretty impactful to Tahoe Forest. And with that said, we've already been thinking through and solidifying what a plan B looks like. If worst case goes through, then what? If part of it goes through, then what? Working with facilities in Dillon Crosby, we have multiple iterations of what would look like our construction or facility investment plan. So we've taken those things into consideration just as we watch hourly what transpires. Do you want to?
I just wanted to add that I think Crystal has a pretty good crystal ball, actually, but it's muddy out there. But one thing we know, and I think that is reflected here in on page 39, is that we don't know exactly how things are going to take shape, but in terms of the pay ranks, we know the government programs won't be seeing the growth that they've seen in recent years. And that's not just coming from the feds, that's even coming from the state. So I think that is really why Crystal sort of held it. We're not sure that we're going to see huge, reductions in the roles there, but we're going to see something, whether it's benefits, whether it's all the supplementals, but we don't anticipate the kind of growth that we've seen in the government programs, in the last 5 years. That's just, does not look likely. And so I think, again, and there is, as Crystal said, this is really designed, if people roll off of those, because if we don't see the growth, that means that people are rolling off, actually, then you'll see that kind of in the bad debt category and in the charity care. But again, it will be in the details, but we are getting pretty clear message that the growth in the Medicaid and particularly Medicaid, but even in Medicare, is going to be slowed a little bit. And I don't think a bunch of people are going to be kicked off the rosters, though. But I don't think you're going to see people enrolling, coming back on in the same way as things like work requirements and other things. Back to that redetermination, stuff. So I think we're going to see a stabilization of these programs that have had massive growth in recent years.
Crystal, can you again just, I think the way healthcare finances work is a little different than a lot of other businesses.
Definitely.
For those that may be watching, that when we talk about gross revenue, that looks like a really big number.
Sure does.
765 million. We're sensitive to that. We hear it in the community. Tahoe Forest makes a lot of money. Contractual allowances take up a big chunk of that, and that's a term that may not be really familiar. Can you spend a second and just walking through what is the contractual allowance? How do we arrive at that? Is that a negotiated number? Does that depend on who our, which insurance companies we're working with? How do you? Because the more real number is the 374. That's what we will get paid for the service that we provide.
That is correct.
And there's a delta of 415 million. So can you just explain that a little bit?
Sure. I sure wish we were like the grocery store, which the price posted is exactly what you're going to get, but it just does not work that way. So contractual allowance is based upon either what was negotiated with a payer like Anthem Blue Cross or Aetna or Cigna versus how we've agreed based upon our structure Medicare will pay us, or how we've negotiated with a Medi-Cal managed care plan. All those are different. We could have an insurance company we rarely see that, will pay us $1 for $1. And then we have, that's not very often, by the way, very, very rare. And then we have other kind of one of the lower reimbursed payers, which is like Medi-Cal, where we could see 20 cents for every dollar we bill. So when we say gross revenue, that's the dollar we bill. And then when we say contractuals, that's the 80% we don't get from Medi-Cal. And the net revenue is the 20% or 20 cents that lands on a check that they send to us that we then can use for investment in expenses or construction or equipment or that sort of thing. So each payer is totally different. And we actually have to calculate break out our revenues by those categories, apply what we've negotiated or contracted or agreed to try to get to what we think is going to be the cash that comes in our door. But boy, do I wish it was a one-for-one. The other part of that is charity care and bad debt. So charity care is also referred to as financial assistance for those that might have high dollar bills and a lower income, and the affordability factor of them being able to pay those bills. We offer that financial assistance to them. It might mean we write off 100% of their bill. It might mean we write off a portion of that bill. There's a variety. Charity care used to be specific for emergency services only. That has now evolved way beyond just emergency services that we offer that financial assistance for. Okay?
Thank you.
You're welcome. I did want to touch on the other operating revenue real quick. You might ask kind of what is that? Well, we have a lot of programs that generate operational revenue that aren't necessarily patient-driven, or actually they're patient-driven, but they could be like the thrift stores, or it could be like our children's center, our great cafe, their sales, but it also includes some of our supplemental funding. And so in this category, we have what's called the Hospital Quality Assurance Fund and the QIP program, which way back when used to be called Prime back in the day. And it's a quality incentive program where if we meet certain metrics, then we're rewarded with dollars for that. So we have budgeted $2.8 million in expected revenue generation from the QIP program, and we have another $3.2 million in there for the hospital quality assurance fee. The Incline facility has been participating in a provider tax as well. In 2025, that was actually favorable for Incline based upon the structure, but starting in 2026, unfortunately, it is not favorable. So we will put more dollars into the provider tax program than we get out. So it's actually a negative for Incline Village, unfortunately. And it's because they see us as a private critical access hospital over in the state of Nevada instead of a public entity like they do in California. So we get treated a little differently over there. It's very bizarre, but. All right, let's jump down into some expense categories. Salaries, wages, and benefits. We had budgeted 3% for what I would call staff positions. And then there is a 5% in there for physician or provider salaries and wages. At the time we created.
Sorry, can you show me where that is? Because that was the curious I had, was that I saw the 3% wages, but I'm looking at this and I'm seeing 0.08%. So can you clarify where that exactly is?
Where are you looking?
In the narrative. So in the narrative, we have.
3% and 5%.
Yeah.
Okay.
And where am I seeing that on the operation expenses?
So that's all going to be rolled onto the line of salaries, wages, and benefits.
At the bottom, the total operating. So operating, so salary, wages, and benefits, not that one line of salaries and benefits, it's all of those.
It's under operating expenses, the very first line, salary, wages, and benefits. So that's going to account for wage increases, FTE increases, and, I know, I should mention this. So the projected 2025, this is the first year I've done this, but there is no doubt we have met our numbers financially. There's no way we're dropping below budget. So when I projected additional dollars for gain share and incentive comp. And because where 2026 does not have that level of dollars in there. So that's one big difference. And the reason I did that is because when that ends up getting paid out, which is November of 2025, which is fiscal year 26, it will affect the cash flow statement. So when I was doing the cash flow statement, I wanted to make sure I accounted for that, because you would see a drop in our cash position for the payout of the gain share program and the incentive comp. So I normally do not do that, but there was no question in my mind about meeting the two metrics that were required for the gain share program. That's why you're seeing only a $1.5 million difference when you're comparing 25 to 26. Does that make sense?
That was a lot for a doctor to understand.
Okay.
so
You want me- I'll roll it back a little bit.
Please do.
You would have to take out probably equivalent to 14 million
Okay.
out of 2025. That is related to the gain share program, the incentive comp program, the benefits that then get calculated on that, like FICA, Social Security, retirement. And so all of that got accrued into 2025. That does not exist in the numbers for 2026.
Okay. I think I got it.
Yeah. And so in 2026, if we do really well, I'm going to accrue those two things again, but they're not budgeted
Not
for.
budgeted for it, but the plan is that it will get there and.
We have to
confidence in
execute.
there.
We have to execute before those things get paid.
That's what I want to hear. Perfect.
Exactly.
That's exactly perfect. Thank you.
And I know in 2025, the two metrics we will hit and we will execute those programs.
Thank you.
Yes. Now I see why you were confused. Okay, the other thing I wanted to make note is typically we have by classification and per the MOU, what our increases are going to be by category. Like RNs will go up by X, clinical lab scientists will go up by Y. We did not have that data yet when we had to put the budget together, so it only contains a 3% right now. I will tell you, I received that yesterday. And the increases definitely exceed that 3%. So we are going to be running what the increases actually look like through the budget after Jay gets a little R&R. And then we're going to have to balance that going into 2026. So that might mean some FTEs we thought we would fill, we won't. But it's upon us to balance that delta that was created by not having that information at the time we put the budget together. We also, in this section, talk about increases in FTEs. And FTEs can be a little challenging because, for example, in 2025, we are trying to fill some positions. So they're budgeted for, but we're not necessarily successful in filling that position. So it remains open, but we're going to continue to recruit for it. So if you look at budget 2025, it might be a 1.0, but in actual 2025, it would be 0. But then we have a 1.0 again in 2026, and it's because we're going to continue to try to fill positions to maintain what we would see as core staffing. So that's some of the FTE growth if you were to compare to 2025. We had positions that were approved in 2025 that weren't budgeted in 2025, and if they started mid-year, they would have only been a 0.5 because it's only a half a year. Now they're a 1.0 in 2026. So not all of this is added brand-new FTEs. A lot of this is kind of keeping core staffing, keeping positions we know are necessary, and visually putting in the appropriate 1.0 FTE into the budget. That doesn't mean there aren't some new FTEs. We have purposely put some brand-new positions into our budget. As you know, we've created a business intelligence department to really help us become a very data-driven organization, and we've added some additional FTEs there. We also have our process improvement department as we embarked on management systems, and so we've made some FTE investments there as well. So there's a smattering of that through the FTE section of your budget binder that talks about what we've added and kind of moved around.
Crystal, question?
Yeah.
When we allocate for a new physician FTE, what traditionally does it take in terms of other FTEs to support that position?
Usually, for sure, an MA. That is a medical assistant. So if you got a 1.0 doctor starting, you usually have a 1.0 medical assistant starting. Anything after that, we try to see if we can accommodate within the structure that they're going into. For example, the second floor of our cancer center. We have a number of front receptionist or office personnel in the front. Just because we add a doctor doesn't mean we necessarily need another receptionist up front. So it's usually at least an MA, and then we look at how it operates after that to see if there's more that needs to be considered. So we had Dr. Hoff join us, our new ENT. He would need an MA. We have 2 physicians, both named Dr. Kellogg, as they're married. And those will each need an MA. We also have a PA going into our GI area. That one is almost a like for a departure of a provider with this provider coming on. We don't think we needed to add much more, maybe a half an FTE for that provider because they're from a part-time status to a full-time status. So we do take that into consideration when we have new providers join as well.
Can I
Absolutely.
add to that? So one other, I think, as we looked at this budget and as Crystal and I have been planning for next year, I think that is a really good question. And I think we are thinking about what kind of position control do we need to think about, and how do we sort of daylight some of this, the standard work. I will say, if the business intelligence, if you looked at the increase in outpatient visits, you won't see a correlation directly one-on-one or anything with the FTEs. So there are dividends coming back from the standard work, from what we're calling the management systems, which I'd like to rename, but we haven't yet. But, from that work around improvement work. And I think that we will be able to, be much more refined in answering that question next year when we sort of say, what does an FTE get us in terms of what kind of system does that FTE need to be surrounded by, and what does that cost? And then also, what does it equal in terms of access? And so we are really working with business intelligence to be able to answer those questions, and that's all actually budgeting and how you forecast. So, and we don't have the entire answer to that. I'll just say I haven't been able to find the entire answer to that, but that, again, is because there's been so much growth so quickly. Yeah.
Well, I was trying to fold in the 5,000 new patient visits that we're anticipating in the management report for tonight's
Yes.
meeting, with the FTEs that we're projecting, and and then the division between those FTEs that are related to patient care and those FTEs that are related to management systems and those kinds of things, and trying to see if there's any correlation there, and I couldn't find it. But I didn't know really.
I'll have to think about that, Mary, to see if there's a way to make that correlation a little better for you going forward. I will say historically, when we've had a provider, like one provider would come with 3 FTEs. They would have front office, back office, and an MA. And we don't follow that anymore because of the infrastructure we've created and the spaces we've created where we don't need as much of that support for an added provider. The things where you'll see growth as well is, for example, the access center. When we add providers and we increase visits, those are all scheduled visits. Someone's got to schedule those. That's our access center. So you'll see growth there. There are some areas where we have not grown over the years, even though the outpatient arena has exploded. Like Jay needs a senior accountant. So there's some incremental areas where we've made some small FTE additions just because we haven't over the years, and we're now pushing just the extreme edge of burning people out if we don't get additional resources in here.
Yeah. If I ever want to know what a company's doing, I always look at their job board. I look at who they're hiring, right? I'm actually really pleased, if I'm reading this chart correctly, the areas I see sort of the biggest numbers: patient registration, access center and central scheduling, business intelligence, which is great, community case management, administrative support is probably the biggest number. These are all areas that we've heard a lot of feedback from both internal staff, community as well, of kind of high priority areas for the organization. So am I safe in assuming that that's reflecting sort of the importance of the organization by saying we're gonna put people behind each of those efforts.
There are absolutely, you mentioned patient registration. We found that we needed to add an additional financial customer service representative. We've also needed to add 2 financial counselors to assist our patients in navigating their bills, just for example. In community, there were some additional resources around the community health index work that we're doing. We've got investments in some of our purchase service categories related to that. So we certainly have put those things within this budget.
Good.
Taking a quick peek at time here. Professional fees, I'm going to say there isn't anything terribly exciting in this category. A lot of this is primarily driven by either medical professional fees for our providers that are not employees that still support the health system. We still have some anesthesiologists that are contracted, a radiologist that's contracted, things of that nature. Legal fees when we need them, that can be managed from our own in-house legal counsel department. We have some fees in here for IT. We are looking to do some expansion with Mercy on some of their modules that requires a statement of work with Mercy and Epic, and that's considered a professional fee, so that's in here. We also put a little bit of money in here as we begin to explore what you might recall from the board retreat, which is, I called it North Star, True North, whatever you want to call it, to help us on that journey to make sure our direction of the healthcare organization is where we want it to go. So just a few dollars in there to possibly assist us with that. We also have some additional dollars still with Vizient as we wrap up our 2-year, 2-year project we have with them before we allow it to completely be taken over and run by what will now be our internal process improvement department. Supply costs, this shouldn't be a shock to you. We're looking at 5% really on medical supplies, food, non-medical and office supplies, 10% on anything that's really patient-related, patient chargeables and pharmaceuticals. That's just inflation alone. And then we also adjust our supply costs based upon our actual volumes. So if we saw higher volumes, our supply is going to go up and then add inflation. Purchase services are our maintenance repair. I do want to talk about this category primarily for our telephone system. We are looking to replace our ancient telephone system that we have at Tahoe Forest. Some of the programs we use now, those vendors had literally doubled their prices for the services that we use, and there's probably 5 vendors I can think of that literally doubled their pricing. When we are able to move to our new telephone system, that support from those vendors would be greatly reduced or eliminated. So we have a period here where we're going to have crossover as we remain on the new and try to remain on the old and implement the new. So this cost is a little higher this year than we would typically see it. Let's see. Other expenses, a lot of other expenses are controllable. Outside education, travel, marketing costs. We can choose to do those things or not. So I call those very discretionary. That did not come out right, discretionary. And so when we find ourselves in a bind, or if we find ourselves in a bind, these are one of the first categories to go. So even though we put them into the budget, doesn't mean we will necessarily spend those dollars. We are expecting utilities to go up. Our insurance costs did go up. We also anticipated a little bit of physician recruitment costs and some equipment rental. So those are the primary changes in that category. The rest is kind of straightforward. Our taxes are our taxes. We try to estimate our interest income based upon the amount of cash we carry in the bank. You'll see in the forecast, I have begun to drop that percentage down. We are not expecting to see interest rates decline. We're expecting them to recede again. So we went conservative there. One area, donations. Over at Incline, the Duffield Foundation did contribute towards the construction project for surgery over there. 3.6 million of the 3.8 identified is the transfer of funds for the first phase of that project. And then in 2027, there'll be another 4.2 million that will come at the completion of the project in 2027. And those are the highlights, I would say, of the 2026 budget. Questions?
Thank you. I mean, that's amazing. It's a huge undertaking, and thank you so much for explaining it and giving us the time for that. And thank you. I think I want to just go pull up one more. I should have asked this question earlier, and I was trying to find the right time. So excuse me, just to pull back up to the very beginning of the variance that we're projecting, like 4.8% at Tahoe Forest, and I want to include Incline. I keep saying when we talk about Tahoe Forest and Incline at 6. Again, as someone who can talk to the community, like obviously, thank you for telling us like, the political landscape, how things are changing, how we want to make sure. I mean, I love this town. I love living here. I want this hospital to succeed. I love this hospital. We want it to thrive. It's one of the biggest employer here. To answer questions and to build trust, to continue to build trust with the community. If someone were to look at this and say, okay, Rob, that's great. Get it from there. Let's look at last year, right? I mean, if you look at your years of year-to-year increase, right, going back 13%, 14%, 10%, 13%, that's a lot, right? And if we look last year we budgeted 4.1%, but we ended up going to 13%. What can I tell the community, right, to build more trust, to say, obviously we're changing, but they may say, hey, like that's what you did last year, right? You budgeted less and made more. What can we say to the community to like help us continue building more trust with the community?
So those dollars did not necessarily come from rate increases. That came from volume.
Okay, perfect.
So if you were to look in the volume section, there are
outpatient volume is huge.
several categories that were a lot more. And some of that's timing, right? We're recruiting a physician. We don't know when they're going to come in. We start them slow. They take off faster. They're generating ancillary labs or x-rays or surgeries we weren't anticipating. Those are really hard things to predict when you're putting together a budget. So we have never done more than a 5% rate increase in any year. And there are years we've chosen not to do that. And we have absorbed those inflationary costs. That's not exactly the most smartest thing to do, but we did do that. So the 5% rate increase that we put on gross revenue actually only ends up being about 2.5% for us.
Okay.
And when you see our expenses, and I'm talking about 3% on wages, 5% on wages, 10% on supply costs, utility costs going up, that doesn't cover those increases.
Okay.
So I'm hopeful for the added volume to help offset that delta because we're only seeing 2.5% on that revenue line. The other thing to note, with the Office of Healthcare Affordability, it's still alive and well, unfortunately, that we're moving into the era where we will be very limited on what we can do on our revenue. So they're viewing increases in revenue from a net revenue perspective. So their perspective, cost to them is the out-of-pocket cost to a patient. And an out-of-pocket cost to a patient is our net revenue. So they do not want our net revenues to go any higher than 3.5%, and then it's going to drop to 3%. And so when I say I'm doing 5 and limiting us to 2.5, I'm already below that threshold. So any increases beyond that 2.5% mean we got it from volume. And we're going to have to explain ourselves to the Office of Healthcare Affordability because they're going to think, they don't know that's volume. They're going to think we did that in a different way. So it's going to be interesting to go forward to see what we can do. We're not limited from growth. We're limited from what we can do with our pricing. And so inflation going forward will be very difficult to absorb if we don't have the volume to offset it.
No, thank you. I think as you mentioned, it's very hard to predict growth.
Yes.
I think COVID definitely brought a lot of people here. It overwhelmed the clinics. It basically put a lot of stress on. Yes, it's nice to get increased revenue from that, but I can imagine that it's put a lot of planning that needs to be forward to make sure we go forward and we still support a growing community.
So I would love to take a moment, if we're done with this piece, and just touch on the capital. Awesome. Capital and cash flow actually are two of the most important things. So in your capital expenditure section, which would be page 56 of your binder, I'm sorry, I do not know what page that is of the board packet, but
Okay, we have the booklet.
yay.
For the public, do you know what page it is in the board packet? Same.
Okay, just a couple of page difference, okay. So, when we go through this process every year, we ask our management team to think about what do they see on the horizon, and to look at their old equipment, when they think it's going to expire, how much longer can it be supported, what's the importance of getting this new piece of equipment? Is it mission critical, high, medium, or low? And so we get our requests in, and sometimes I feel like they think it's Christmas, but so we get our list and we compile and take a look at what the requests are. Typically, I will take the medium and the lows and roll them to the next year, because in my mind, those can wait unless they just critically break, and then we'll deal with it at that time. So I usually focus on the mission critical and high, and we incorporate the medium and lows into our long-term capital investment plan. So right now, we're looking at equipment of a 5.6 million between IT, EMR, infrastructure. Think of that as, computer related, software related. We're at 5 million. That includes the telephone system. And then the building projects is probably the biggest category, of course, at 55.6 million. In these categories, I have included costs such as surgery over at Incline Village. Even though that's being funded by donations, we're still listing it in this section. And things that are reimbursed by the municipal lease are also in this equipment section or the construction, and we will draw those funds out when we complete those projects. So that's in here. On page 58, you will see the breakdown of those expenditures by quarter, which is what I utilize when I do our cash flow projections. So I can try to predict when those funds are going to go out the door. And if you wouldn't mind taking a step back before I go to the long-term capital plan, if you'll go back to one section, which is the statement of cash flow, you will, 54. On page 54, I have listed the most current data from Standard & Poor's for days cash on hand. We are striving to be A-, but at no point would we ever want to drop below BBB-. So that range is 112 days cash on hand to 243. At the end of 2026, I'm projecting we'll be at about 182.7. So we're right in between BBB+ and A-. And that's with, I'm going to say, even though it's not A-, we have intentional purpose with those cash funds for investments going forward, to start projects and be able to complete those projects in 27 or 28 or whenever they end. So I feel very comfortable with that projection, and you'll see when we get to the financial forecasts, what I call we're in the green zone on our ratios. So, and you'll see that broken down by quarter. The lowest quarter we will have is the second quarter, which is about 186 days.
Crystal, can you go back to the statement of cash flows?
You bet.
And tell me what's wrong with the A days of cash on hand, the A-rated days of cash on hand?
There's nothing wrong. Yeah, it actually drops. I will show you that on the page in the financial forecast. Yep.
So to just make sure, I'm sorry, go ahead, is that Mary?
So it went from 201 as an A rate and
Yeah.
243.
Yep. So let's pop to page, it'll be helpful, page 74, which is in your ratio analysis and financial forecast section. It's almost the last page of that section, second to the last. So these were the ratios that were published. Green represents, it's the best ratio in the categories, and the red represent the worst ratios. For the most part, red is all triple B minus, where you would expect all the great to be double A plus, but you'll see that is not the case. There are some categories where lower rated organizations might have a better ratio in that category. Days cash on hand happens to be one of those. So A minus is 243, but A is 200.6. And that is how the ratios were published. So the other ratios, though, for an A minus weren't nearly as strong as an A. So it's just a couple of those ratios are just slightly out of balance.
Okay, thank you.
Yeah. Which it was kind of hard because when I was comparing ourselves, I'm like, do I say we're not great because we're over 200 but under 243? So I was like, no, I'm using 200 as a floor. So if we exceeded 200, I'm going to say we're in the green zone. You're welcome. All right. Because I'm going to ask you to approve the multi-year capital plan, I would like to take a step back one more time to capital expenditures, specifically page 59. Okay, so on page 59, you'll see our fiscal year 26 capital budget of $66.2 million. In 2027, we are looking at $59.5 million. 2028, $29.3 million. And 2029, $31.7. Medicare requires us to have a 3-year capital plan. In the 21 years I've been at Tahoe Forest, I've been asked by a surveyor once, but once is enough. So from that point forward, we always bring forth at least a 3-year capital plan. Of course, I need 10 years to do the financial forecast. So that's why you actually have the next page, which is page 60. But the only one I'm going to be asking you to approve is page 59 to demonstrate to CMS we have been forward-thinking and have identified the capital needs of the organization.
Can
I think this is another important complementary point to the discussion we were having earlier about people see the money and wonder. And I think Crystal and I did it back of the napkin a week or so ago about, let's say we were to take the cuts as is, making their way through Congress and apply it to 2025 revenue, which is not as straight because we do get some cost base and all that. But I wasn't even counting the supplementals, and I was coming up with like over 12 million. So maybe that's not a thing this year, but that would be, in a worst case scenario, year over year over year. So we're already stressing about 2030.
Yeah, exactly.
So that, and which is, you pay us to do that. But that is, those numbers, when you have like a $60 million capital plan, it's like, okay, we could absorb it. But when you start to go out and you're like 3-4 years from now, where we have 19 million or 31 million, 29 million, 31 million, and then you start going out farther, that's a big deal. And so these are some of the, again, I think some of the reasons. And I think it's an important thing to point out, that you point out to us around building trust. And I think what we can do is really take the time to think about how we communicate these things so that people can know that it's really about making sure we have an investment strategy and a savings strategy, if you will, or a financial management strategy that ensures the district health system will be here for generations to come.
I think it's important for you to know, we did provide the detail behind all the capital and the construction within your portal for viewing. To just make a couple of notations, we have absolutely included dollars to begin and complete the Gateway project, which should add additional exam rooms and help increase our ability to see more patients. We've got dollars in for our Dollar Point, Tahoe City, Fabian Way. I don't know which one you know it by, so I'm using all three. We have dollars in there for that. Also, the Sierra Center, which we formerly known as Rite Aid, where we are relocating our community pharmacy, expanding our urgent care, having occupational health over there. So all those projects are absolutely included in these numbers, as well as some infrastructure in our imaging area. A lot of the investments we've made are getting ready to sunset and be at the end of their useful life. So we just replaced the CT, or the MRI and the CT. We still have X-ray, we still have fluoroscopy, nuke med, we have the PET CT scanner, and we also have the LINAC in the cancer center to replace, and those are very large projects. And so that's been accounted for in this capital plan, as well as just maintaining our normal infrastructure, our mechanical projects, and some dollars there to still address seismic, which we've been required to do. So that has all been incorporated in here. Some things we've waited on. For example, when Sierra Center is complete and we move the urgent care out of the medical office building across the street, what are we going to utilize that space for? What type of construction might need to take place for that? There are some dollars allocated for that, even though we don't have the plan completely dialed in. We've at least planned some dollars to be able to account for that in our future years. So that's why you're seeing kind of those ebbs and the flows and the dollars out 10 years. And really the last 3 years, actually the last 5 years are pretty hypothetical, but the last 3 years just have placeholders because we don't have plans that go out all the way to those remaining 3 years of the 10-year capital plan.
There's a big bump in 31 that seems intentional. It goes from 25, 27, 14, and all of a sudden bumps up to 38. What's going on in 31 that we're expecting?
2031.
Page 60.
Yes, I know. I'm going to the details so I can answer your question. So 2031, we're still dealing with some seismic. We're dealing with the MOB first floor, possibly remodeling that. We have electrical distribution replacement that we need to do. Possibly the childcare modular building replacement. So that's some of the stuff that's out in 2031.
You mentioned imaging a handful of times. I think a lot of folks around this town would understand building and construction costs, but imaging is millions of dollars, right? I mean, we talk about it almost in passing, like, oh, new MRI, $6-7 million
Yes.
for that, right? So I think it's important to understand that there's expensive equipment in the building.
There is, but I'm so glad you brought that up because to Anna's point earlier, some of the investments we're making, especially like in the Sierra Center, we're trying to really identify ways that we can use where we're putting our outpatient lab draw station, that we can actually process some lab tests there, which would allow us to really drop the cost or the price to the patient for those lab exams and make them much more affordable. So those are the things we're exploring with these new spaces to really address that affordable option complaint that we hear consistently. Imaging's a little more challenging because you have to duplicate some very expensive equipment, but potentially we could start with X-ray, which isn't not too bad, but to try to put another CT scanner in Truckee on an outpatient setting is much more challenging. But we're definitely trying to take the right steps in the right direction to try to start producing some options for affordable care. All right, so we covered 2026, we covered the capital. Would you like to touch on forecasts real quick? Wonderful.
Yes, please.
All right. So I'm going to start on page 62. So page 62 represents, in some regards, how S&P would analyze, Standard & Poor's would analyze our financial information to calculate our ratios. It is a little different than what we do internally because we don't recognize our tax revenues necessarily as operating revenues. We show it as non-op. And they also want us to include the GO bond, not only in the tax revenue, but also in our long-term debt, which isn't entirely fair because operationally, we're not using operational dollars to accomplish that. But, excuse me, that's why you're seeing calculations that say no GO bond, which means I've excluded all the GO bond information out of that. And then if it doesn't say no GO bond, that means it's included. So with debt, it makes our debt look higher, but honestly, our ratios still look pretty darn good, even with the inclusion of the GO bond debt. But that GO bond debt is, let's see, almost 20 years old now. So we only have, I know, at least the first round from, I'm like, oh my gosh. So it's not as young anymore with the amount that's outstanding. So what is before you is a few years from our actual audited numbers, 2019 through 2024. The projected 2025 are the same projected numbers you saw in the very beginning of your budget binder and how that calculates into the ratios. I will tell you anything that's green on this page means it's A- or better. Anything that's yellow is, I call it, we're still in the neutral zone. We're between BBB- and BBB+. And if it's red, it means we actually dropped below what would be BBB-. And I will say the only category we really have that in is our days and accounts receivable. But one of my arguments I've always had for that is our payer mix. Commercial payers take the longest to pay you compared to a high government payer mix. So if we were more Medicare, Medi-Cal, we would get paid faster, we just wouldn't get paid as well. So there's a trade-off there. So right smack in the middle is our budget 2026, and you'll see the only classification that's yellow is our days cash on hand, which we already spoke about. And we're still expecting some improvement in our days in the ER to be at 58 days. Behind this page are my projected balance sheets and income statements going out 10 years. It's a lot of numbers on those pages. I just want to hit a couple of highlights. I did not increase our inpatient room and board revenue any more than 2%. I did not increase our outpatient revenue any more than 4%, and in the later years, even less. There is inflationary factors in there of 3% on wages, 3% on professional fees, 3% on purchase services. I've kept the same ratio of supply costs to net revenue that we've been seeing, so it accounts for inflation. And I have projected that all the way out. And then I did not increase anything for volume. Volumes are completely flat and these 10 years out. So the revenue growth you're seeing in those future years is ChargeMaster only. And so based upon that and some very conservative, not conservative, I probably should have been more conservative, inflationary increases, you can see as we go out to 2035 that really the only numbers that still stay in that neutral zone is our days cash on hand and our days in accounts receivable. The days cash on hand on the cash flow projection takes into consideration all the capital in that 10-year plan that you were just looking at, takes into consideration a decrease in interest rates, does take into consideration the second phase of the municipal lease. The board approved up to 10 million, we've only done 6, so there's a potential for another 4, so that's been incorporated in here. And charity care and financial assistant and payer mix are all relatively neutral going out these 10 years. Based upon that, you'll see that, we have a declining net income as we extend out. It's still a positive net income, and it does keep our ratios in a very positive zone. So what we don't have built in here is all the conversation at the federal and the state government. That could easily, absolutely wipe out some of these numbers if some of the more heavy hitters come to fruition. The reason why we do these forecasts is to know that what things look like that we know today and where potentially we need to go in the future. And so at this juncture, I'm going to ask you to put the federal and the state over here for a minute. At this juncture, we are in good shape to move forward with our capital and construction plans as presented. We could go get additional debt, which is the second part of this section, to the tune of $50 million to help fund some of these projects. It would be 30-year debt, but it would make some of our ratios not as strong, but would bring our cash levels up. So it's a trade-off. Other ratios are going to suffer, but our cash position would improve. But now we're carrying debt for 30 years as well. So this is to get a feel for the wins ahead. And when we talk about 12 million, 15 million, and if that compounds over these years, you'll start to see that if we did nothing, that would erode our bottom line. So we must tread very thoughtfully and very prudently going forward, understanding what the federal and state government is doing and the impact it has on Tahoe for us. So the forecast is really just to give you a whiff that if the federal and state would play nice, we'd be pretty good. I'm happy to go as deep as you want into this category, but it's a lot of numbers, it's a lot of information, and really that first page of trying to show you green, yellow, and red is trying to give you a simple dashboard to know how things look based upon what we know today. Any questions on that?
Yeah, holding volumes flat, what's the thinking behind that when all we've seen is volumes?
Yeah, so without knowing where the volumes are going to come from, what the pair would be related to the volumes that it would create, we know we're going to have more exam rooms over in Gateway. We can see more patients, but does that mean we're still going to have more volumes per year? Or is wait times just reduced, so we still have the same volume, just less of a wait list? So those are the crystal ball things that I just don't have the skill set, honestly, to project out 10 years. Are there areas I think we'll tackle? Yes, just because of our construction. Based upon market information, are there some services we might want to add that we're considering? Of course we are. But those are still so new that need to be vetted with a business plan. I'd rather not build them in, knowing that if we do build those in, they should have a good financial pro forma to only improve the situation. Or if it doesn't improve the situation, it still has a financial pro forma, and we absolutely know the ramification of putting dollars towards a certain program.
I'm just bringing a question, so give me a moment. I think in healthcare, we want to be conservative, right? You want to do what's right for the patient. No one wants to take risks with a patient. So thank you for mapping out the vision, the why. We want to be here. We want to be here forever. We want to be successful. Markets change. I guess my one question is, what's the risk of being too conservative, right? If we're saying, okay, we want to make sure we're ready for all these things, and I think you mentioned, and I think that's where maybe you could elaborate, if there's another project, you mentioned if there's something that we need to get to, is there a risk of being this way? Will we have more? I love that what you said, the balance of patients waiting and access for that, and so I think in your what could be if things go really well? What could we be what do we need to be nimble about? And I think we're small enough and fast enough that we can respond to the market. So I guess does that make sense as a question? Perhaps I can rephrase it.
I would like to answer the question at the CEO, and then
Yeah.
let the CFO answer the question also as the CFO. And I would say one thing about the risk of being too conservative, I think I think what you're asking, I think the answer to that question for me is, what is the risk of investing without a strategy? So that is really why we have it within our budget actually built in. I mean, Crystal called it a few dollars, and it is a few dollars, but for that True North discussion, and I will say, as we were speaking, Dylan might have walked you through the capital plan, but he's actually in Alaska right now at the NUCA conference. I think that there's a lot of opportunity here. And there's a lot of opportunity to think about if we want to really, what the health system should be as it relates to the community. And I think one of the steps that we have to take before we can sort of answer that question is investments that go beyond kind of the traditional investments, or into sort of community work, let's just say, or even growth inside of the system. I think being really deliberate about what that looks like. And when you're sort of small and you just kind of can build, that's, you have a little more slack because you're still building. But as you approach kind of the size we are now, you really have to think about what's the market, where's the actual need, what's the perceived need, where could we grow, what are the complementary programs that we need that can support the core programs? Where do we want to have, I'm going to use Dr. Evans' term, like where do we want to have these magnets with a halo effect around the rest of the system? But also, and importantly, is there a gap within the community that it's our duty to fill? And so I think going through that process is going to be really critical. And so I think, to me, you're right. I can't answer to the risk of exactly what's the risk of being too conservative, but I can answer what's the risk of not being disciplined, and that is that you make investments without attached to a strategy, or most importantly, to a need. And then, once we sort of bring the strategy and the need, then we go to Crystal and Jay and say, like, make this financially work. Because we are public, we don't have the luxury of some systems where, and this is probably true in the history of our system. Once you make a promise to the community, you must keep it. And so we have to think about where should we be, where is the need, and how can we do that in a way that we can sustain it? Because, we've all seen, other partners, and they have great programs and they can't sustain it. It may be that we have a plan, right, that we want to do all of this, and there may be a partner that's going under. And maybe we have to come back to the board and say, if we don't sort of step in here, something could happen. So I guess that for me, I can't entirely answer the question until we kind of go through that process. That's my answer, but I know Crystal may have a slightly different answer.
From my perspective, it is my job to be conservative on behalf of this organization. It is my job to produce numbers that we feel are attainable, that we can go ahead and make decisions based off, not, projecting volumes to be, we hope we're here, but if we don't get here and we've already made decisions on some other areas based that we thought we'd be here and we're not, I don't want to put this organization in that situation. So for 2026, I want to make sure that the decisions we're making now that are going to happen in 2026 look like they can be sustainable. And the investments we're making in projects that might take 2 or 3 years, I need to make sure we can finish those, and that makes sense. Now, the too conservative stuff, I'm willing to throw that out the window on my forecasts. But I'm not going to throw that out the window on next year's budget. That's just not where a position I'm going to put this organization in.
Thank you very much.
Yeah. All right, do you want to dive deeper?
In?
No,
Well, no, I think there's, and you might have been leaning towards this in your question. I mean, definitely when we're out and engaging the community, it's not uncommon we're hearing healthcare is too expensive. I can't afford it. They see numbers, net revenue, 24 million, 30 million. The hospital's making way too much money. When you put it in the context of what needs to be spent in the years ahead, that goes a long way in understanding. But it's also, I think, important to understand, these dollars aren't going to shareholders, right? It's not like we're.
don't have shareholders.
Right. Like we're not accumulating profit and people are sitting fat and happy on some hill. That those dollars are reserved for either more capital. But I think what people feel, at least from conversations I've had, is, if the hospital didn't make 24 million this year, my knee surgery could have been cheaper. Right? And I don't believe that's a fair comparison. Right? It doesn't work that way.
I guess I probably shouldn't have said we don't have shareholders, because we do. And that's our community, and that's our patients. And so I'm hoping they feel like the investment we're making in our organization for the level of care, the equipment we can have, the state-of-art facilities that allow them to stay local, I hope they see the benefit of that, and that we really do view them as shareholders. This isn't, we are not a for-profit. Do we need to make a profit? Absolutely. And we need that profit to reinvest. And so I would message it that way. If we didn't reinvest, we would still have our CT scanner in a trailer out in the parking lot. Is that the type of care we want to provide at Tahoe Forest? It's not. Do we want to add additional services that our community needs and will use and makes sense to do at Tahoe Forest? We do. We need to be very thoughtful about what those are, and those require investments. If we want to bring providers to Tahoe Forest and provide high-level providers for care, it takes investment. So, I think every dollar we show on that bottom line goes back into this organization for the future. Anyway.
I think I would just add, if that's okay, I would just add, I actually don't, I think this is actually a question for me versus for Crystal, who, I think we have to do a better job on communicating how, where money comes from, how we spend it, and why, and the reasoning behind it. And I think we need to create space, platforms for people to give us input. And I'm not sure, again, I think that's happened in the past, and I think we've done that, but I think we're at a point again, there's been a lot of change, and I think people are really eager to figure out what's going on in the health system, but what are you doing with all this money, right? But I would also say equally, how can I help this health system? And I think we need to really create the space and platforms for that to happen. And that starts with demystifying kind of all of this. I mean, the number piece, I actually wouldn't suggest that Crystal do anything different, but I think we as a leadership collective, a leadership system, need to demystify this process and figure out places where, like, here is where you can interact with us. Here is where you can make a request. Here is, where you can, lift a need that maybe we aren't, emphasizing and you're feeling really strongly about. And I think so I do think as we walk out of this, that message for me at least has been heard pretty clearly. I'm not taking it as a criticism. I'm taking that as a sort of a challenge to let's demystify this, because I think actually, this is a very solid financial management system that I'm coming from a very different world, and I would not advocate in any way sort of changing sort of our financial management system, but I think communicating that and then how we get inputs into the consideration around investments, I think we have some opportunity. So and it's definitely, I'm not saying a no or conservative, I'm saying that we need to have a deliberate process and some discipline around it. And I think, I'll speak for Crystal in this. No, I've actually not encountered a lot of no's. What I've encountered from Crystal is let's understand what we need and then give me the time to plan for it, which I really appreciate. And I think all of you do too, but I don't think the general public maybe has the benefit of all these discussions that we have. So that's on us to figure out how to get that out there. Yeah, thank you.
Agree, and wonderful to hear. Because you're saying dive deeper, other things you need to or want to cover?
Not need, it's if you have a want or a
Okay.
desire to know more.
Okay, but you've
I've
shared the
hit-
information.
I've hit the highlights. Again, there's information in the back of your binder if you were curious about how we compare. I also give you a very detailed breakdown of our professional fees. That has always been kind of a point of confusion over the years. How much is for like medical professional? How much is for legal? How much is for consulting? So it was more provided to you for information. I wasn't going to review it. But I'm happy to answer any questions on any section that we didn't dive, into detail about, but you have questions on.
I always do think it's worth, and I really appreciate you including this information, because these are the conversations that we have in the community, right? And when you look at pages 78 through 81, it's looking at, revenue per visit, per discharge, et cetera. Tahoe Forest is consistently, if not always, at the lowest level, right, when we talk about affordability.
When you get into pages 82 and 83, this is where we do our California compare, and then we do our Nevada compare. And clearly, there are different regulations between California and Nevada, especially seismic,
Yep.
building infrastructure, that nursing ratios. There's a lot that is very different between Nevada and California. So we will struggle to compete as a healthcare system, as a hospital, with a hospital in Nevada. We just will.
Yeah.
So, but at least you can see for emergency room, we're not too bad. When we can start making, and a lot of these patients have outpatient lab facilities that allow them to charge a lower lab price than a lab price that's in a hospital. So we're moving towards that direction, but at least you can see the difference between California and Nevada.
No, thank you. I think that these pages, and if anyone's watching, I encourage them to look at it, because I think it really does tell the great story of the hard work. And I know that you look to compare and make sure that we are competitive. I think, in our vision to be, the preferred healthcare system in the region, I think we are. I think the one thing is, renown is just on the hill. We get that. That's a hard one. That's a really, really hard one when people are going to say, but Nevada, like you said, so thank you for sharing. I just wanted to echo that. I think that's really, it's a challenge. So thank you I think this is really important sharing, and that this is what we want to do. And I think being at the conference down in Sacramento, and when the Office of California Hospital Accountability already published those hospitals that are overcharging, it was a sense of pride to say, oh, that's not us.
We're not on the
And that's
list.
not on there. We're not on it because of the hard work you do. So already that publicity just shows the hard work. But again, you don't really see it when you're not announced. You're usually announced for something bad. So when you do something good, you usually don't get the credit. So thank you.
But I will say the data they are using isn't exactly reliable either. So I feel for, those surrounding us that originally were on that list, so.
But it's still good not to be on the list.
I know, agreed.
Any other, you tapped out, you said you need no more.
She
No,
talked
I
out.
just, I marvel at the presentation.
Yeah.
I marvel at the organization, I marvel at how it's presented in English, and it anticipates all of our questions and our needs. in advance, and I just so appreciate it, it's wonderful.
Thank you.
I want to just repeat that again. I mean, this is my eighth hearing on the budget, and every year I learn something more about how we come to the numbers that we have. And it has been really interesting watching the inpatient numbers, because that's my background, and how those have changed. And when I looked, I think it was the OB deliveries, last year was an anomaly, and it might have been what was happening in other hospitals.
True.
But when we look at it in the future, it's all slowly growing, so we know there's going to be another generation in this town.
Well, I would like to take a moment to thank Jay. She is phenomenal. I couldn't ask to work. I don't want to work with anybody else. I think she plans to retire before I do, but we'll see about that. But thank you so much, Jay. You're just amazing.
Thank you.
Right. So there are a few items we need to take action on. In my handy dandy cheat sheet, it doesn't call for public comment or audience input. Do we not take that for?
Not on the special meeting.
Not on a special meeting. Okay, thank you. So then with that, item 4.1, and again, this is, we were presented a lot of forecasting, but the action we're taking on is just the fiscal year 2026 budget. So we'll need a motion on that.
I move we approve the Tahoe Forest Hospital fiscal year 2026 budget as presented.
I second.
This is a roll call vote or just a all in favor kind of thing? All in favor?
Aye.
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 All opposed? All right, budget approved 4-0 with our key financial guy, Dale, not being here, so we'll note his absence in the vote. Item 4.2, and again, the reminder, this is just for the 3-year capital plan, not the 10-year that we did review, so looking for a motion then for approval of the 3-year capital plan fiscal year 27 through 29.
So moved.
I'll second.
All right, motion and a second. All in favor?
Aye.
All opposed? Approved 4-0 as well. Crystal, thank you
Shoot.
so much.
I just thought of something.
Oh,
Inclusive of the 5% rate increase.
I was wondering when we were going to do that.
Yep. I need the motion to be approving the fiscal year 2026 budget inclusive of the 5% rate increase. Sorry.
so
We should have wrote out the motion for you.
Yes, because that went right by me.
Director Wrong, would you move to amend your motion, please?
Yes, I'd like to amend my motion on the fiscal year 2026 budget to include the 5% increase.
Effective
August
August
1st.
1st,
August 1st.
2025.
So do we have to re-vote on that? Because
I would think so.
It needs to be reseconded in
Resecond that vote,
in
yeah.
another vote.
Okay, resecond.
No, you did, Rob.
I second.
Okay. So the amended motion for the approval of the 2026 budget, motion and a second. All in favor?
Aye.
All opposed? Second time around, still approved. 4-0.
Thank goodness.
Thank you.
And there was no closed session, so we'll adjourn the special meeting and look forward to seeing everybody in open session in 30 minutes. So stretch your legs.
Closed session in 30 minutes, open session.
Well, we start open, then closed, then, yeah.
When we close, we open.
5 seconds of open.